It's good.
Books, we got lots of books.
So what about this?
This is my water. It's the only way I'm going to make it through. It's actually vodka. And that's actually how I'm going to make it through this whole thing. Oh. I intend to finish that in 5 minutes. All right. Go. Yeah, right. That's how we do. Looks like we still got a minute here, but yeah, I was going to have all the mics and stuff hooked up, but it was just like a real pain to do that.
I understand.
Full setup.
So what is the mic on that then?
No, that's it.
Oh, okay. I got
you. You're looking at it.
It should be enough, no?
Oh, it's plenty. Yeah. But, on a budget, I can't have,
right.
I would have had to come in at like 3 in the morning.
No, you tried some double mics.
I tried double mics,
And echo.
but it actually turned out to be triple mics, and that's why the echo came up. The 2 mics were okay, but then this thing was still working for some reason. And so we were all communicating in the same structure. It was a problem. But yeah, so now we're good. We're all, what, it's interesting in increasing levels of formality. Notice that? Charlie's got short sleeves. I have rolled up sleeves. You have tie.
Is the tie in the center? Because
Is it in the center, like from top to bottom, or just in the top? Where does it matter? I don't know. Looks
it has
good.
to be in the center between these two.
Oh, yeah. Looks good.
Yeah.
Well, don't worry about it. All right, everybody, welcome. Here we are at our weekly live cast. So you got tips on how to dress, how to wear a tie, and today we're going to talk about EMR. And I think for the next few months, honestly, and it might go longer than that, but each of our live casts we're going to start talking about and kind of feeding ICD-10 into it, because that's coming. I think the countdown now, we're 21 days to ICD-10, which is kind of a big deal. So, I remember I was at the FCA conference in Orlando. Actually, we were all there. 3 of us, right? Mm-hmm. Yeah, we were all there. And there were a lot of people there saying, oh, well, we just started talking about it. We just started thinking about it. Maybe one day we'll actually do something about it. It's like, well, you have a month to figure out ICD-10. So, we're definitely increasing the number of codes here. But before we get started, I want to make sure everybody knows about some of our recent developments. So one of them, of course, as part of POI's products, we just released our newest product called FBN Shop. So if you haven't gone there before, it's fbnshop.com. So www.fbnshop.com. You'll see a video on what it is, actually how to set it up. So it's got a really easy setup there. And right now, for a limited time, when you set it up, you actually get it for free, which is really cool. So that's going to be really interesting to see. We're going to be starting up a lot of shops here in the near future. And of course, if you haven't already checked out our books, so all of them are on Amazon, Barnes & Noble, and everywhere else you can find a book. But Medical Billing, Mission Critical, Practicing Profitability, Treat or Be Treated. Only one of these are mine, and so hopefully I'll fix that to write it, maybe 3 or 4 more, and maybe make them a little longer. These books are much longer. Anyway, but let's start with a quick introduction. So to my left is Charlie, who we've had before, I think, maybe just on audio. But Charlie's one of our most successful practice coaches. You work with how many practices today?
About 130. About
130. And not entirely on your own. You've got
I have a great team of people to
great
work
team
with.
of people. Yeah, absolutely. Shout out to Heather.
Yes.
Yes. Okay. There's your partner in crime, or a practice success. And then to my right, I have my dad, Yuval, who's a PhD and CEO at POI. And I think it's notable to mention that he works in a number of billing companies and practice coaching programs with over how many practices today?
In total, close to 600.
Close to 600 practices today. So that's kind of a big deal. And I think the background is worth mentioning. You have a PhD in mathematics. Yeah.
Yes.
So for those of you out there who don't know what it takes to get a PhD in math. You have to be really good at math, and I'm not. So we're not going to explore that anymore, for my own sake. But I think what we want to talk about today is the history of EMR, but insofar as what brought us to today and how that plays into this ICD-10 change. Because everybody thinks that ICD-10 is all about billing. It's all about just memorizing thousands of new codes. And so as a practice owner, as a clinician, I just have to make sure my billing staff is on point when it comes to what they're doing. But that's not true, is it? Is that entirely true?
That's not entirely true.
It's not entirely true. I mean, at the end of the day, it's the billing, but I think that there's a little bit more to it, and I think EMR plays a role, right?
Yes, yes. ICD stands for International Classification of Disease. And people started to think about classification of disease, and prior to that, classification of causes for death in the Middle Ages. And
So burning, hanging, beheading. Sorry, I'm watching a lot of Game of Thrones, so that's the only way I know that people die in the Middle Ages.
so in some way you're right, because actually people did not differentiate between many ways of dying. And actually in different countries, for the same causes, they had different names, and actually they would not agree on the cause itself.
Sure.
And so in the middle of 19th century, there was the first statistician congress where they started to talk about this. And finally, in 1900, on January 1st, they came up with the first ICD-1.
Can you imagine how exciting that group of people must have been? Statisticians.
ICD-1 had listed 179 causes for death.
But it was still just
Wow.
death. It wasn't like, I have this problem and I might live. It's, you died, and there are 179 ways that we think people can die today.
It also included different illness
Right.
names, and actually ICD-1 tells you the level of medical science sophistication,
Sure.
because people only knew 179 ways of getting sick and die.
Sure. My foot hurts. Nah, cut it off.
Yeah.
Yeah, who needs it?
So 100 years later, in 1999, ICD-10 was created. It actually took us 15 years to get to the point where we are actually implementing it in practice. But ICD-10 was already described and documented at the end of 1999. And it had 68,000 names, codes.
Wow.
Isn't that, but that's the thing that's always weird to me is, isn't it true that ICD-10 is actually used today in the rest of the world, or in a lot of countries?
In most of the countries, it's already in practice.
In most of the countries are in practice, and it's called the international,
Yes.
right? And you would think that that would mean that everybody kind of has to adopt it at around the same time. But I guess kind of like the metric system.
It's not just the metric system. It's also, I mean, we have other things that are happening at the same time.
Sure.
That are very important, and they have to do with our healthcare system. So in parallel to ICD-10, in 1966, we in America came up with a CPT, with the CPT codes. And we had 7,800 CPT codes. And we needed those codes because in our system, we pay for service. We
Right.
do not pay for performance, we pay for service. And those CPT codes are very important because those are the codes that go to insurance company, and on the basis of those codes, the physician gets paid.
Right, with the exception. I mean, there are some cases where you'll bill out certain codes to a certain maximum, but even inside of that, an insurance company could come back and say, I want to see medical records because they want to show, for example, that you didn't improve the quality of the patient's life. And so as a result, I should not pay you for those claims.
Correct. Yes.
So it's almost like it turned out to be a combination of the two, but
service
of service and performance, yeah.
Right. Yes, you have to show improvement over time.
Right.
So CPT codes 7,800, and they require 5-digit code to enter this. Incidentally, ICD-10, the system that is
Currently in place. Yeah.
currently in place until October 1, also requires 5 positions, and it
Right, 3
has,
digits and then 2 after the, yeah.
and it has 13,000 codes. So we are moving on October 1 from 13,000 codes for ICD for diagnosis to 68,000.
It's about 52,000 new diagnosis codes. And I mean, honestly, in working with practices on this, Charlie, do you find that people are genuinely afraid of this change? Or do you think that they're just so, it seems like such a big change that they just, what am I going to do about it? What can I do?
I think with the calls that I've had recently with ICD-10 inquiries, a lot of it is the fear of the unknown. They just don't know what to expect.
Right.
You know, so they want to know what they have to do because they don't know what to expect. And I don't know that any of us truly know what to expect from it, but so we've tried to, you know, provide them with a way that they can, you know, make this change as smoothly as possible. Howbeit, you know, again, the unknown is what payers are going to be ready, what payers are not going to be ready, who's going to be ready to accept the ICD-10 codes, who's not going to be ready to accept the codes, and how all that plays into their fear of, well, am I going to get paid? Because at the end of the day, that's all they care about.
Right.
Am I going to get paid, and what do I have to do to get paid? Because I'm providing a service. I just don't know what I'm going to get paid for this service now, because now I have to put a new code on there or a new diagnosis in a format that I'm not even familiar with.
Well, think about the change to 5010 in terms of just claim submission. How
Absolutely.
many insurance companies were on the go live date? And I mean, I remember just from our standpoint, we were starting to submit in 5010 and getting communication back from insurance companies after go live saying, hey, we're not ready. You have to go back to previous version.
Yeah.
You know, so I can't imagine that the same thing's not going to happen here.
So there are 2 kinds of problems that arise with using ICD-10. The first one, like you mentioned, now instead of 5 digits, I'm going to use 7 positions.
Right.
And I need to enter them correctly, because unless I enter them correctly, the insurance company is not going to recognize it, and my claim is going to be denied.
Right.
Exactly.
And by the time I correct it, now I've lost time, yeah.
Yeah.
And then I may run into timely submission.
Yeah, well, I mean, I think one of the basic things with timely submission is as long as you get the claim out the door and they say that they got a claim for you for the date of service, it's okay. But even then, I think that there's a limit to the point, to the extent that I'm going to work on this claim if it takes so long to get it right. You know, and that's where those kind of things like GEMS mapping, where it automatically gives you the crosswalk. But even then, you're not getting a one-to-one, right?
So the first problem, there are 2 problems. The first problem is actually entering correct code. And GEMS actually is one of the ways of making that transition easier. But in principle, it cannot be foolproof, because you have more codes. Instead of 13,000, now we have 68,000. So the old code does not correspond to just one new code.
Right.
Any old code corresponds to several new codes, and now you need to pick the right one.
Right. Right.
So you still are left with the choice you need to make correctly. That's only first part of the problem. The second part of the problem is validation of the claim. So we have validity rules. There are all kinds of validity rules, claim validity rules. One of the kinds of validity rules is called diagnosis to procedure. In the simplest example, we diagnose that your hurts, then you should amputate your toe.
Yeah, that's a great example of what not to do. Well, and I want to talk about that for a few minutes, because when you think about these validations, right? So on our platform, so one of POI's products of Oracle, if you're not familiar with it, is a practice management solution with records and billing and scheduling and all that stuff. And one of the big things that we have right now is a library of rules that we've learned of over 2.5 million different validations, billing rules. One of the things that really allows us to turn billers into managers. I mean, that's one of the most powerful things I've seen in going into an office today with ICD-9 is I can go into an office, and Charlie, you must have had this experience. Mm-hmm. You go into an office where they're doing the billing in-house, where basically what that means, they have a biller making the phone calls every few minutes, well, hopefully, and getting information about claims and going through aging reports and all that nonsense.
Yeah.
And you walk in and you say, well, you're way too smart for this position. You shouldn't be spending your time on the phone with insurance companies. You should be spending your time making this process smoother and having someone else make those phone calls for you so that you're focused on creating efficiency and increasing cash flow for the office, which validates not only your pay, but a positive return on investment for the provider, right? And you know, even when you have 1 or 2 or even 3 people who are working on that, depending on the size of the office, it's much preferable to having them making the individual phone calls to insurance companies. Now, one of the things that I want to know about is going to ICD-10. I mean, if diagnosis to procedure code mapping creates X number of combinations of codes, right? And you add 52,000 to one side of that equation. I mean, how many combinations are you creating? I mean, a lot more, right?
So we just increased by an order of magnitude the number of codes.
Yeah.
So the number of rules is going to increase by 2 orders of magnitude. So
that's that math thing.
And we don't have those rules. Nobody has them.
Well, you can't have them because nobody's had the experience of what happens and what the insurance companies expect.
Right.
Do the insurance companies even know what they're going to pay for and what they're, I mean, there's 2 codes, for example. One code is for when you get struck by a turtle, and one where you get bit by a turtle, which I think is actually an example of how ridiculous this is. But I mean, how does an insurance company today know if they're going to pay on a procedure relative to being bitten or being hit by a turtle? I mean, how did they make that judgment? Is that already decided on, do you think, or are they going to have to decide later?
So the good news is you're going to get paid for the procedure that you administer.
Right.
And you may administer the same procedure regardless whether you're hit by a turtle or by an elephant.
I don't know. I mean, if I get hit by a turtle, I might need bed rest for a concussion. If I get hit by an elephant, I might just need a morgue.
So, yeah. And that's what defines really the value of the reimbursement.
Right.
The procedure that you administer at the end.
Mm-hmm.
But if you are administered the procedure that generally is administered because of being bit by turtle, while actually the diagnosis that you made has nothing to do with getting bit by a turtle, then this claim is going to be denied.
Yeah, but how do they know?
So,
I mean, how do they know that the procedure for being bitten by a turtle is not the same procedure you would use if a child bit you? You know, I mean, in other words, shouldn't there be...
They have medical officers on staff.
Right, so in other words...
Specialists. But
yeah,
the challenge is for a small office or even for a hospital,
right,
is to figure out the changes in the rules that happen because of the introduction of ICD-10. And unfortunately, those rules are not published. So everybody needs to discover those rules on their own. And of course, your discovery will be faster if you submit more claims, because your denial rate is going to be higher and you will be exposed to more cases of denials.
And not just the number of claims, but also the difference in the number of procedures and diagnoses that you're dealing with. So in fact, it's actually more than just the number of claims, but actually the number of different things that you're doing in your office. So a perfect example is the multi-specialty, where you're submitting across multiple specialties in a single day and at high volume.
Right. So if you compare two offices, two medical offices on October 1st, and maybe those offices are differences in size. One has one physician and another one has 10 physicians. So they have more or less 10 times more volume of claims. Chances are that the second office with 10 times more claims will learn the new rules 10 times faster than the smaller office.
Right.
And so that's where, well, and the volume is not enough. In addition to having enough claims to go through, you also need a team of experienced billers who actually analyze the denials and come up with new rules that need to be implemented in their systems.
And also, I mean, I'm thinking also of the clinician. You know, a biller notices that they're seeing the same issue over and over again that the clinician is making when they choose their codes. And more, I mean, one of the things that we see a lot is that a lot of clinicians will seek to offload the coding part of their documentation to somewhere else. And we're seeing more and more that this is becoming less and less of a possibility, that more and more insurance companies and regulations are requiring the physician to be more and more responsible for coding. And I mean, if you're a biller and you're noticing that your clinician is not coding correctly, I mean, what are the odds that he's maybe not, or she's not even documenting correctly? You know, if, in other words, you have to figure out where there's that consistency or inconsistency, the two.
Right. And you have to combine this with the feedback from the billing, from the insurance company, and that feedback in the form of claim denials.
Right. And I mean, so one of the questions here that I was thinking about was deadlines for responses. So today on, 12, 13,000 diagnosis codes, an insurance company, some insurance companies have like 30 days to get back to you and tell you that there's a problem. In other words, by law, they have 30 days to get back to you. Can we really expect the same kind of turnaround time on 58,000 diagnosis codes? Are they going to be required to meet that on October 1 still?
Yeah, absolutely.
But do you, I mean,
there is no provision for changing the response time expectations.
But if I'm Joe Schmo chiropractic or Joe Schmo physical therapy, Joe Schmo MD, and insurance companies just can't keep up with the number of new codes and getting back to providers as quickly as before. I mean, it's not like I have the financial capacity or even the time to now litigate on one claim or even 100 claims. How can I afford to now chase after an insurance company on a rule, right? It would have to be these large hospital networks that have teams of lawyers on staff. So as a practice owner, it's almost like, yeah, they should get back to me in 30 days by law, but what am I going to do if they don't? What's my recourse?
Yeah.
Right?
No problem.
I mean, that to me seems like one of the biggest potential issues is if you're not able to catch enough of those errors before the claim leaves to the insurance company, right? Aren't you gonna potentially give yourself that problem? right? If you rely on the human ability to catch all that stuff, you're going to miss out on a lot of payment potentially with all these changes, right?
Absolutely.
So, so where else? I mean, what else are we talking about with getting the diagnosis to the procedure code matching? I mean, we're talking about an increase in the number of potential rules, right? So today, let's say we have 2.5 million rules, more than that, but 2.5 million rules, let's say, for ICD-9. So I think what you're saying then is for ICD-10,
well, not all of those rules have to do with ICD.
Right, some of them are procedure. Yeah.
Some of them procedure to procedure, some of them have to do with geography, with
demographics,
yeah, right. So all of that is, but the part of total rule number that has to do with ICD is definitely going to be much larger. And the problem right now is that we don't know.
Yeah, but if it's orders of magnitude, I mean, even if it's only 500,000 rules today for ICD-9, then we're talking about 50 million rules potentially for ICD-10, right? I mean, that's incredible. And I think that brings back the point about insurance companies getting back to you quickly. I mean, unless that's completely automated, how on earth?
First of all, you have to be automated. This was the need for automation was noticed in the middle of the previous century.
Yeah.
And actually, the name that comes to mind is Dr. Weed. Dr. Weed noticed in 1966.
In Colorado. Dr. Weed. I couldn't help myself.
Yeah, let's see. Dr. Lawrence Weed.
Huh.
And yeah, he said the physician's unaided minds are incapable of recalling all the necessary knowledge from the literature and processing it with data from the unique patient.
He probably had a lot of friends in his, in his colleagues. You guys, we're all dumb, and we can't remember anything.
He said this at the time when ICD in 1966 had 4 positions and 4,700 names.
4,700 diagnosis codes.
4,700 diagnosis codes. The code had only 4 positions. And at this time, Dr. Weed said, the physician's unaided mind is incapable of handling this. So he said, let's use computer to document patient visits. And he came up with, he called it problem-oriented medical record, which was the precursor for today's SOAP. And he came up with a subjective, objective assessment and plan. And he gave all kinds of examples, and he actually built the program. It was one of the first electronic medical record programs implemented on a mainframe computer.
The punching computer? The hole punch?
Well,
It's one generation later.
At first it was with punch cards, but already in '67 they had a visual monitor, and they could print out. And one of the issues was that until then, until electronic medical record arrival, there was the medical record handwritten were pretty much illegible.
Right,
and
like
so,
prescriptions.
Right, and so Dr. Weed came up with all of those important ideas where already in 1966 he recognized the need for computer to assist in documentation of diagnosis. That was the number of diagnoses was 4,700, when today it is 68,000.
well, in 21 days, it'll be just counting down. It's the 9th today. In 21 days, it's going to be 68,000 codes.
Right. So manually, it is in principle impossible. But there is another thing that plays here, which is called Pareto rule, where we know that 10% of the codes deliver 90% of the impact.
Right. As a clinician today, I might use 20 diagnosis codes in my office, and so if I increase that by an order of magnitude, though, that's still 200 codes I need to.
Right. And so as the number of codes increases, and actually the increase in number of codes is the reflection of a major trend happening in medical profession, which is specialization. And 100 years ago, or 150 years ago, a doctor was a doctor.
And the barber was your surgeon.
Right. And
cut your hair and I'll sew you up.
Right. And they did everything. I mean, they
doctor was your doctor.
Right. So it was relatively easy to remember less than 200 codes.
And you're really only dealing with people who died, so it's even easier then.
And the life expectancy was 47 years. At the turn of the 20th century, the life expectancy in the United States was 47 years. It took another 50 years to change that life expectancy to 67 years.
Wow.
And that brings up a whole different conversation about when people should retire.
Well, and then in 2000, it became 77 years.
Right.
So, which is this trend of increasing life expectancy is a reflection of better medical care, better standard of living, and specialization. All those things keep showing pretty much that they all kind of work together. And none of it was possible without the aid of the computer.
Right.
So the challenge that we have today is just a reflection of the general trend that we all experience, which overall, I mean, we're all going to benefit from that.
In principle, when the computers take over, then we should live forever, right?
Absolutely.
It shouldn't be anything like it is in the movie. So, okay. So it sounds then like, again, it's getting more and more complicated, but again, we have specialization. So let's say that in my office, I use 20 diagnosis codes and I use 6 procedures generally. I'm that specialized. Generally, I'm doing maybe 6 things in the office with my patients and for 20 different reasons. And so I've got X number of combinations. But if I now have an order of magnitude more diagnosis codes, so now I've got...
You're going to have maybe double that. You're going to have more specificity.
Right.
So if you handled an elbow, so now you're going to tell which elbow is this, left or right.
And what part, well, and also maybe what side of the arm.
Right.
Right.
So maybe you're going to have twice as many codes. It's not an order of magnitude. And your specific rules for validity of your procedures are not going to grow by such a huge number. But there will be more, and you will need to discover them.
Right, right. And I mean, that's one of the things that I'm noticing more and more in working with groups like PBS, for example, and in the past having worked with groups like CBP and all them, is you see more and more the trend of billers becoming or spending more of their time in a supervisory position where they're not in the weeds making phone calls now, but now they're actually in a position where they're trying to come up with processes and leverage technology to help an office better automate and better take advantage of those things, right?
Yep.
And those practices, I mean, I've seen it a few times, those practices that are unable to make that evolution, that jump into taking their in-office staff away from the individual tasks and to the larger picture, tend to really struggle. I mean, their collections suffer as a result. You know.
Of course. I mean, if you don't use observations that were made today, you may get away with this. But if you don't use observations that were made 50 years ago, you know, you try to do everything manually, you try to memory manage your patients and your practice.
And your billing.
And your billing and everything else, you're going to fail.
Right.
Actually, it's surprising that your practice is still.
It's a testament to how well you can memory manage that it's actually still open. Yeah. No, but it still comes up. I mean, people say, well, no, I went to a few ICD-10 seminars. I'm totally comfortable as a biller. I'm going to totally be fine doing the billing every step of the way for the office, working off of aging reports. I mean, I don't hear it a lot anymore because those people either no longer exist or, you know, or recognize the need to grow and evolve.
Right.
You know, and honestly, your life gets easier. That's one of the things I noticed the most.
Mm-hmm.
You know, the life of the coder, the biller, becomes so much easier when you're focused on strategically making the office more efficient and automated and justifying your position that way, as opposed to on each individual claim and saying, hey, I got that claim paid.
Mm-hmm.
Who cares? You know, as a biller, I figured out how to get this entire set of claims paid in under 20 days, as opposed to when it usually took 40 to 60 days and I only got 80% of them paid. Other people are making the phone calls, but I figured out how to get that done. And I'm going to maintain that because things are going to constantly change.
Yeah.
So your position is always necessary in that way.
But it is much more productive.
Much more productive. And now the clinic owner doesn't have to do it. Right? And you're not expected to do both anymore, which is just unrealistic.
And all that became possible because of the clever use of the computer technology.
Yeah. Thank you, Eris, for that. He's not here, but we thank him anyway. So you know what? I think that that is a huge start to understanding a little bit more of how EMR and ICD-10 have changed and how they grew into what they are today and how connected they are, and how important it is that both are treated not as separate, exclusive things, but as things that depend on each other. But I mean, I have at least 10 or 20 more questions, and I'm sure other people have questions as well. And actually, between now and the next time we keep talking about this, I'm going to be collecting those questions that come in through Twitter and Facebook and all that. And I'm going to bring them in because I think people are going to have really good questions. Are there any suggested resources other than our books, which you should absolutely get? But are there any other resources that you guys are giving to people for ICD-10 and prepping themselves in terms of ICD-10, EMR, all that?
Well, we have a webinar on ICD-10.
Yep.
That was just done.
Was just done.
And that was with Jason, our COO, and with Kathy, correct? Is that Kathy?
Or Jessica.
Or Jessica. But we did that with our team.
Yeah.
With our team, yeah.
Okay.
So that's the main thing. And there's a hotline.
Okay, so there's a public hotline for that, and I'm sure that there are going to be a lot of certification courses coming out, not necessarily for ICD-10 certification, but for people who are coders and billers. I'm sure there already have been those, but as ICD-10 rolls out and they start discovering rules, they're actually, I imagine they're going to start having those courses on just some of those rules in small groups.
Yep.
So I think that that's something to look out for too.
Yep.
Okay, so our next live cast is going to be with Eris, actually, he'll be here, and we'll be talking about technology in healthcare and kind of what the future holds, not just for our products like Vericle and FBN Shop, but also for technology as a whole, you know, the things that are interesting that are coming about. And it's actually pretty impressive because a lot of the things that are coming out today, it's not like it used to be, where you know, people who spent years and years in school, you know, are university professors who are doing all this work. These are, I mean, some of the things I'm reading about are coming out of kids in their junior and senior year of undergraduate study.
Wow.
Yeah, I mean, these are 20 and 21-year-old kids who are basically changing healthcare from the clinical side and from the technological side. So it's amazing.
Yeah, truly amazing.
There are a couple examples of just kids, I mean, high school kids coming up with ways to save money and make things more efficient in hospitals. It's incredible. So we'll talk about that next week. And then, again, everything that we're talking about, so even that we're going to tie into ICD-10, how technology is changing in healthcare, what does the future hold, you know, and how does that tie in with this change with ICD-10, and we're going to start tying in what we're learning here. But, you know, one of the major things that we benefit from is that because we submit so many tens of millions of claims every month, as ICD-10 begins to roll out, we're going to be discovering a lot of these rules very, very quickly, especially since one of our Vericle as a product is a learning product. I mean, it's an artificially intelligent thing that is constantly generating and learning from the claims that are submitted and figuring out what those rules are. And then our team translates them for the billers. And I'm actually really excited to see what those new rules are going to be.
Absolutely.
So so look out for that, and we will continue next time. Awesome.
Thank you. All right.
So now we just need some play out music, right? Like on the news.
There you go.
Right? You just need to go. Somebody needs to play music. Charlie, just start singing, right? Isn't that what we need?